Is a important topic and one that we've covered in pretty good detail in the meeting pretty much every year. But we thought we'd take a little bit different spin on it this year, and we're going to have cases to illustrate the utility and the place of imaging, particularly the highly sensitive imaging, ultrasound and MRI, and to do it in a case-based way. I will remind you also, when you talk about ultrasound, that this afternoon's workshop is the musculoskeletal ultrasound hands-on course, very popular, and some very nice machines available to us, and Dr. Wells runs that. Well, let's start off. We're going to bring Dr. Wells and Dr. Troum up here, and we'll let them go through and teach us about the use of imaging in a case-based way. Do you want to sit there, or whatever you guys want? Just start up here.
Okay, I think I'll start up here and welcome back, and hope you had a nice break. And something very near and dear to both of our hearts, and hopefully several of you have been interested and have followed some of this literature, how we use advanced imaging. I don't call it now modern imaging because ultrasound's been around for a long time, as has MR. Actually, there's the Nobel Prize has been awarded to the folks that discovered MRI. This goes back 30 years ago. So what I'm going to do is give you a case presentation of a patient that I actually saw, give you some of the EULAR recommendations for the use of more modern imaging, and Alvin will give you a case of psoriatic arthritis, and I'll come back with the last case of RA. So this is a 71-year-old female that presented with an incidental shoulder injury in April of 2012, subsequently developing pain and swelling in the hands and wrists, morning stiffness and neck pain, but no headache or visual changes, remembering she's 71. And labs that she came to me with prior to her visit showed a SED rate of 37, elevated CRP, normal CBC, although her platelets were elevated, and a normal chemistry panel. Past history for hypertension, right knee arthroscopy, medications for her hypertension and some intermittent ibuprofen, and otherwise negative significant rheumatic disease history. And her review, systems unremarkable, social history, she didn't smoke, just drank slight moderate wine per week. Blood pressure and her vital signs as you see there. Temporal arteries weren't tender, some decreased lateral range of motion. In examining her, I thought this was probably due to osteoarthritis. But she had significant tender and swollen bilateral wrists, tender right and second and third MCPs, and PIP joints bilaterally, decreased finger flexion. 6 out of 28 joint count, 6 out of 28 tender, and 2 out of 28 swollen joints. So as you start thinking about the new ACR EULAR criteria for rheumatoid arthritis, you're certainly thinking about this in this patient. That was my impression. She had an inflammatory arthritis compatible with RA, but needing to rule out other connective tissue disorders. So my plan at the time was then to check some of her serologies, rheumatoid factor, CCP, ANA, hepatitis serologies, a TB spot test was done. I'm already thinking about therapy that I'm going to be offering this lady today. X-rays were ordered. A chest X-ray was ordered. Physical and occupational therapy that I think is critical, at least in my implementation, having patients coming back to a good functional status. I did give her a non-steroidal and a proton pump inhibitor. I discussed updating her vaccinations, and I initiated disease-modifying therapy that day. So now to come back a little bit and look at the utility of imaging in assessing rheumatoid arthritis, the role of X-ray has been with us since we started assessing these patients, determining joint space narrowing, erosions, and possible soft tissue swelling. But that's insensitive for soft tissue swelling and other structures other than the joints. The role of MR, it's more sensitive than conventional radiography in assessing synovitis, osteitis, and erosions. And ultrasound is also more sensitive than conventional radiography in evaluating synovitis and erosions. So I'm going to give you now the EULAR recommendations that were published just last year for the use of joint imaging in managing RA. So initially, making the diagnosis, and you'll see the strength of recommendation after all of these recommendations. So patients with at least one joint with definite clinical synovitis, recommendation 1. When there's diagnostic doubt, Conventional radiography, ultrasound, or MR is used to improve certainty of RA diagnosis above clinical criteria alone. And you may remember that the initial EULAR ACR recommendations didn't even have X-ray in their way to make the diagnosis of RA. Recommendation 2, presence of inflammation seen with ultrasound or MR is used to predict progression to clinical RA from undifferentiated inflammatory arthritis. That's strength of recommendation almost an 8. 3, detecting inflammation and damage. And this is critical in patients when you may not see that on your physical exam. So both ultrasound and MR superior to clinical exam in detecting joint inflammation, and you should consider their use for a more accurate assessment of inflammation. Recommendation strength 8.7. Recommendation 4, conventional radiography of the hands and feet should be your initial imaging technique to detect damage. But what if you have a patient with very early onset and it may not show that damage? Consider MR and or ultrasound if the X-ray doesn't show damage, and it also may be useful in detecting the damage at an earlier time point, critical for when you might pull the trigger or make the decision from going from conventional disease-modifying therapy to more advanced therapy. What about prognosis in RA, predicting outcome? Well, recommendation 5, MRI, bone marrow edema, and this was mentioned, Marty Bergman brought this up earlier, in osteoarthritis, and just to briefly mention that, that is more of a traumatic or edema, true edema. When I consider edema, I would think it would be water. It's more like a water content as opposed to what both he and Vibeke talked about, the inflammatory infiltrate that's seen in rheumatoid arthritis that has been proven by biopsy. Jimenez-Bosch published that several years ago. It's a strong and in fact, the strongest independent predictor of radiographic progression and erosions in early RA. So it can be used as a prognostic indicator. And synovitis detected by MR, or even more easily by ultrasound, as well as joint damage detected by conventional radiography, MR, or ultrasound, are considered predictors of future joint damage. Again, good strength of recommendation. How about the prognosis in RA predicting response to treatment? Inflammation seen on imaging may be more predictive of treatment response than clinical features and can be used to predict response. Monitoring disease progression. Given improved inflammation detection by these newer modalities over clinical exam, it may be useful in monitoring disease activity. Strength of evidence, 8.3 out of 10. Periodic evaluation of joint damage, hands and feet, usually are done by conventional radiography, but when I ask my colleagues how often do you do an X-ray, some say I do it at baseline and others say I do it at 1 year, and then the numbers drop off significantly. But it should be considered also when looking at these newer imaging modalities because it really can be used to monitor disease progression. Monitoring cervical spine functional instability by lateral X-ray, flexion and neutral, should be performed in patients with cervical involvement with RA. But if there are neurological symptoms, an MR should be done. Very high recommendation strength. And then the 10th recommendation is using ultrasound and MR to detect inflammation that predicts subsequent joint damage, even in clinical remission. Another key factor. You think the patient's in remission, and you see, and Alvin hopefully will be able to discuss this also with ultrasound, a smoldering synovitis or tenosynovitis, suggestive what is the true definition of remission? And I wanted to point out this one study that both Dr. Strand and I were co-authors on, Dr. Raghunath out of UCLA, have published, and several others that were part of the American College of Rheumatology Clinical Trials Task Force imaging group that I'm a member of, and Dr. Strand, the Outcomes Measures in Rheumatology, MRI, Inflammatory Arthritis Working Group, the OMRAC group. And what this paper that was published last October showed, and something I've been talking about for a long time, but now we have sufficient evidence to really suggest this, that it reviewed the available data addressing the utility of MR assessing joint damage, erosions, cartilage loss, joint space narrowing, and the precursors to damage before you have those outcomes, osteitis, the bone marrow edema, and synovitis in rheumatoid arthritis randomized controlled trials. Without going through the whole paper, the systematic literature review and meta-analysis, MRI met the OMRAC validation filter for truth, discrimination, and feasibility within RA randomized controlled trials. What does that mean? That MR offers evidence of structural damage inhibition in a shorter amount of time and with fewer subjects compared to conventional radiography. Thus, we may be able to bring newer products, newer molecules to market by doing clinical trials in a shorter period of time with fewer patients. Back to our case. So this lady comes back. She's following up now to discuss her x-rays and plan. She now has 4 tender and 2 swollen joints. The lab test that I had ordered shows a normal rheumatoid factor, normal CCP, hepatitis panel is negative, borderline positive ANA may be seen with a patient in this age group in her 70s, and a negative ANA panel. Her x-rays, I'm sorry for how that projects, basically showed some soft tissue swelling over the MCP joints, mild narrowing of the left metacarpal joint, classic finding of osteoarthritis of narrowing of the first carpal metacarpal joint, and what was considered cystic changes of the carpal bones, and there was some radiocarpal joint space narrowing in the lateral view. The MR, the low field in-office extremity MR, showed several erosions and cortical irregularities in her carpal bones. So this was quite different in this tomographic view of what these bones look like, and the arrow starts to point out that cortical erosion on T1 weighted imaging. And similarly here in the left wrist, scaphoid and capitate bone erosions, not seen on conventional radiography. Early patient with rheumatoid arthritis. And similarly here, some irregularities and erosions. So the MR did show another erosion in the hand, a 7 millimeter significant erosion in the third metacarpal head. No other evidence of synovitis, osteitis, or erosions in the hand, as was seen in the wrist. So what you see here is basically a hole in the bone. That was completely covered by the x-ray above and potentially below. If any of that bone is intact, you don't see this erosion. Tomographic views will pick that up. And just to show that this is almost called or sometimes called a tunnel erosion, you see that it's broken through the cortex of the bone. This is a true erosion. And you see here osteitis by short tau inversion ratio or STIR imaging. No contrast was needed to pick up this inflammatory lesion directly where we see that erosion. So a 3-month follow-up of this patient, now on methotrexate, 20 milligrams a week, folic acid supplementation. She has 2 tender, 2 swollen. She's still active in regard to her inflammatory mediators. She's in moderate disease activity by DAS28 and also by CDAI. A biologic was added at 3 months, as opposed to potentially increasing her methotrexate, maybe using it sub-Q or maybe using other DMARDs. So subsequently, her tender joint count went down to 2, or remained at 2. Her swollen joint count was now 0. Her SED rate normalized. She was in DAS remission, and the plan there was to continue in 3 months. So that's how I utilized this advanced imaging to help me advance to further therapy quicker. She had poor prognostic indicators. Despite the fact she was 72, I felt we could capture this disease quicker, and we moved on to biologic therapy. Alvin.
A quick question while we change it over. Remind the audience, what's a pathologic erosion? You said 3, 4, and 7 millimeters. Which ones really get you excited?
Getting me excited about erosions. Clearly there can be 1 or 2 millimeters that may not be active. If you see STIR imaging positivity, or if it's a patient that has contrast, that there's activity there, any size erosion potentially could, but a 1 or 2 millimeter, not as impressive, and depending on where it is. So sometimes you see erosions that may be far off to the side, as opposed to, as I showed you, one directly in the middle of the bone or just at the edge of the bone may also make a difference.
Okay. Hey, just curious while we get started, how many people in the room have access to an MRI, either in the office or readily in the clinic? Okay, significant. What about ultrasound? How many people do an ultrasound? Yes, asking what, Roy, how
many use it?
Yeah, so how many people will use the MRI in a case like Dr. Troum described, in those kind of early cases, kind of define and see which group to put in? So it's a significant amount. Okay. Well, let's go through another case. So yesterday, Jack Cush, who I thought talked very fast, came and said, Alvin, you talk really, really fast. So I took my Zoloft and propofol this morning. Not propofol, propranolol. Propofol, yeah. It's the other P words. I'm going to slow it down a little bit and go nice and steady here, even though I had the caffeine on. This is you.
Yeah, yeah.
So what I did, I put together kind of a case, and this afternoon in my disclosures again, we're going to do some different cases for the workshop and really going to focus on some non-articular uses and talk a little bit about coding, because that's been up in a lot recently in the news with what's going on. But I'll show you how we use the case here. So this is a typical case of what we see. A 37-year-old man with a 6-year history of plaque psoriasis. Again, the dermatologists in my area, I don't know how many of your areas, they don't really treat a lot of skin disease, chronic skin diseases. Glenn, they make more money doing Botox injections and tattoo and hair removal. The groups that I find, if they do have a nurse practitioner or a PA, they'll do acne, dermatitis, and psoriasis clinics, but otherwise they send those patients out to primary care or to the rheumatologist. He had been on topical steroids and vitamin D creams, used a tanning booth because, it makes him feel well all over. He has had some neck pain that's been controlled with ibuprofen. He has, however, developed some significant foot and heel pain that's not responding to the ibuprofen. So he was referred to a rheumatologist by a primary care physician because his left foot pain and some swelling. He was concerned about gout or other causes of arthritis. On physical exam in the rheumatologist, his weight is 83 kilograms at the BMI of 33, so he is overweight. BMI, remember, over 30 qualifies a patient for any of the approved weight loss drugs. Looking at the skin, he has psoriatic lesions of the scalp, elbows, knees, and if you do a rough estimate, about 10% or maybe even a little more when you put those numbers into there. As you all know, many people with psoriasis, they got these funky looking toenails. They were told they had fungus of the nails. Turns out many of these people have this dystrophic nail changes like this gentleman had, involving the second and third toes of his left foot, but did not have any significant pitting that I could identify. And when I look at his joints again, everything was normal except for he had a decreased inversion, eversion of the left ankle and had a trace of a fusion of the ankle. But if you look at the area of the Achilles tendon, this is where we saw a significant amount of swelling and erythema around that left Achilles tendon. Laboratory values that were obtained on him, CBC, rheumatoid factor, ACPA, set rate, CRP, were all negative within normal limits. Many of my patients coming in, their primary care doctors usually do a good job, particularly some of my high referring doctors. They know what kind of labs I would do. So many people, like we talked about in the hot seat, I'm not going to repeat their labs because they refer to me. If I do a labs, they had a rheumatoid factor within a month, then they have to pay for that out of pocket. So we see them. He did have an elevated uric acid level of 7.8. His doctor was also concerned that this gentleman might have gout, being a little bit overweight, and was concerned about that. X-rays had showed some mild osteoarthritic changes of the left first MTP. Otherwise, there was nothing really that was seen on the X-ray of the foot. So we brought him in and we did an ultrasound scan, and the typical scan, I'll show you some anatomy pictures here. One of the nice scans we like to do when we look at the ankle is do this anterior longitudinal scan, and what we're looking for the tibia-talar joint. That's a nice joint where you can look for erosive type changes. You can see osteoarthritis in those areas as well. Just as an offside, we actually use viscosupplementation in those areas if somebody has significant osteoarthritis and they don't want to get their ankle fused by the surgeons. And then we also turn that transducer at 90 degrees, making sure we can look at the margins of that joint space, looking for erosive changes, looking for narrowing of the cartilage, and looking for other signs of inflammation as well. One of the unique features about the ultrasound, unlike the X-ray, X-ray only shows you bone. A surrogate marker for cartilage loss is going to be joint space narrowing. But when you do the ultrasound, similar to when you do the MRI, I'm able to see all the other soft tissue structures. I can do a dynamic evaluation of that ankle to see if those tendons are moving or tracking along the margins of the malleolus like they should be. With the MRI, the difference is a patient has to, of course, sit there for 45 minutes or so until they attain these images. The key area in this patient, when you look at the area where he has the pain, is very nice. If you push on the ankle or the heel, say, hey, you're having pain there, that's why I'm going to put my transducer to see if I can see anything that might be pathologic. The nice thing about when a rheumatologist does, I say, if I wrote this guy to say, hey, the radiologist, get an ultrasound of the left ankle, that's all they're going to do. So he comes in, I say, hey, if I see some change on his left ankle, I'll compare that to the right side to see if there's any difference, see if there's anything that's going to be different, because there are some subtleties, and this is one of the difficult parts about ultrasound. There is a little bit of learning curve that you need to know what the normal variations are and what's normal in that individual patient. I'll show you what that looks like. And then this is an image we're going to look at the most. So again, if I'm worried about psoriasis and a patient who might have psoriatic arthritis, I'm also worried about enthesitis. And remember the entheses, and we talk about this, this is where these tendons are attached to bones. There's a lot that's been published on this in the last few years. Now we believe that the entheses actually indeed is a true organ. If you look at the number of structures, the number of cells that are there, the tension and the forces that go along those areas, and this is where we can see these changes here. Now with these new advanced images that Dr. Troum was talking about, we know that other joints can have these entheses as well. For example, look in the interphalangeal joints. These are areas you can see. So sometimes those people with psoriatic arthritis, you push on their PIPs and their DIPs, they're going to be tender. You're not going to see the swelling and the puffiness like you see in a rheumatoid patient. But if I do an MRI and ultrasound, I can actually begin to see some changes that might be suggestive of enthesitis in those areas. Remember that when you're looking for enthesitis, that this is looking for inflammation, you look for changes around the tendons, and remember these areas also, there's new bone formation in these seronegative diseases. Like Glenn showed you early on, so seronegative arthritis, these patients get these overhanging osteophytes of the small joints. The same thing can happen in areas of the heels. They can also some bony changes or bony proliferation there. So this is what you're looking at. So this is a patient looking at the Achilles tendon. The head is going to be here. Here's the bottom of the heel. Remember the tendon, like several other structures in the body, are avascular. The tendons get their nutrients from the blood vessels or in the tendon sheath, the paratendon. If you see blood vessel inside of a tendon, a blood signal on the Doppler like this is pathologic. That's abnormal. So here we look at the Achilles tendon, and right along here, look at the calcaneus, and then we see this little bit of spur, this hypertrophic bone formation that we see in there. Just for completeness sake, remember back behind, underneath the Achilles tendon, this is the area of the retrocalcanea bursa. So if you are going to do an injection, that's the site that you want to have your needle in. And then I think on this next slide, I kind of draw the little margins here. Look at the detail. This is one of my older machines. We have several machines in the clinic, but you can look at the skin. You can see the thickness of the Achilles tendon. Here's a normal calcaneal bone. You see this little bit of uplifting of the sheath right in there, and that's what you're looking for, that hypertrophic bone formation. That's suggestive of enthesitis. In this particular gentleman, then we looked at his Achilles tendon and we saw all these different things here. So you saw this kind of signal that you look at. That is all abnormal, high signal, lighting up like a Christmas tree. And then we also was worried about, hey, does this patient have any potential for gout? He had a fluid. Again, not to go through all the orientation, but you see fluid accumulation in that tibio-talar joint. You can see all the fluid here. And that you can come in with your needle to begin to tap that fluid and make the diagnosis to see if he has gout. Remember that many patients with psoriasis, because of the cell turnovers, their uric acid levels will be high. Does somebody have gout? So this is the images I think many of you have seen, that the ultrasound is pathognomonic for gout. So if you look at an area like, say, of the femoral condyle, the cartilage of the knee, you can see the cartilage to be nice. We used to think the cartilage was anechoic black, but on these new advanced machines, the cartilage does have some detail you can see on ultrasound. If you look at where uric acid is, it actually layers on top of the cartilage. The uric acid crystals are too large to penetrate the cartilage itself, so it layers on top of that, giving you what we call a double contour or railroad sign. Comparing that to chondrocalcinosis, those calcium crystals are smaller, so they can actually penetrate the cartilage, and it layers inside of that. It looks like somebody's taken a piece of chalk and drawn it through the line of the cartilage, and that's what you look at. So we do this on our patients with psoriasis if they have joint complaints, to making sure, hey, he's got a uric acid level of 7.8. We know now he should be treating to less than 6. Does this man need to be on any uric lowering therapy? And this kind of shows you again, here's a tibio-talar joint. You can see a little bit of fluid, a soft tissue inflammation in those areas. But again, not a whole lot that lit up on Doppler. And this guy, the money was in his Achilles tendon. So I'm looking at just a scan of the tendon here. These tendon fibers, look at all that fluid. When you see fluid again inside of a tendon, it's pathologic. Is it coming from a tear? Is it bleeding inside of that? This guy has some issues, some trouble going on. Here's a tendon sheath, and then we can begin to pick up part of the calcaneal bone, looking at that transverse view. And then when I put the Doppler on, that lights up like a Christmas tree. This guy is all inflamed due to the involvement of enthesitis of his joint. So the question on this guy, he definitely has psoriasis, psoriatic arthritis, and we use this to say, hey, based on what's seen on those tendons, this is not gout. This is probably enthesitis related to his underlying disease. And then the question is what we talk about and get into treatment and everything here as well. We're going to go back and jump into the next case, and then we'll kind of do a summary, talk about how we can use imaging to help guide our treatment on patients with these diseases. Okay, Dr. Troum?
Thank you, Alvin. So this is the second case of a patient with RA, a 52-year-old that presented to me for a second opinion. She was diagnosed in March of 2010. Medications at the time were meloxicam, methotrexate low dose, plus folate, and low dose prednisone. She still complained of morning stiffness, pain, swelling of hands, wrists, toes, and elbows. And a few days later, the labs, CBC chem lipids were normal, vitamin D was low, rheumatoid factors, CCP, were unavailable at the time of the visit. PPD was positive in 1980, but treated with INH. She was a non-smoker and non-drinker. Family history was negative. Review of systems, as I mentioned, and her physical exam showed normal vital signs, although she was quite overweight. An extremity exam showed synovial thickening, tender wrists, MCP, PIP, MTP joints. She had a flexion contraction of 20 degrees of the right elbow, 10 tender, 7 swollen joints. No doubt here that this patient had active disease. So she had rheumatoid arthritis, positive PPD, status post-INH, treatment for 9 months, vitamin D deficiency, and obesity. So the plan, just to clarify some of her serologies, CCP, rheumatoid factor, ANA, hepatitis serologies, TB spot, because actually this is a patient that had a positive PPD but was from an area that BCG vaccinations were given, so I wasn't sure about that, despite the fact she'd been treated. X-rays were done, chest X-ray, OT, PT, vitamin D supplementation, and just at the first visit increased her methotrexate to 15 milligrams a week. Followed up, she had now 6 tender, 6 swollen joints, significant improvement. Slightly positive rheumatoid factor, significantly positive CCP. Hep panel is negative, ANA, just a positive ANA, negative panel, and still active disease, and she had a very significant DAS28, negative chest X-ray. X-ray showed some narrowing of the right third PIP joint, if you see it there, some juxta-articular osteopenia, as was mentioned earlier by Glenn. More X-rays. Nothing significant there. An MR of the right hand was done, showing a subchondral erosion of the proximal head, as you see there at the arrow, very well detailed, and significant osteitis there, very active disease, and also a metacarpal head erosion with significant osteitis and erosions in the wrist. Multiple erosions in the wrist. So I increased her methotrexate, recommended additional therapy. She was reluctant. Now we go a few months later, slight improvement per persistent symptoms. Sed rate was still elevated. She had 4 tender, 4 swollen, still in moderate disease activity. And we continued her methotrexate and prednisone, but recommended adding a biologic. A month post-biologic, significant improvement, with now 3 tender, 1 swollen joint. 3 months later, no tender, 1 swollen joint, sed rate down. She's in remission by DAS scoring. So again, another modality to help me in assessing my patient in the short term in regard to how this patient was managed. And I think that's the last slide we have. I'm going to just mention this because you see the cards outside. I'm president of this organization, the International Society for Musculoskeletal Imaging and Rheumatology, and Alvin and I and several international and national faculty, both from ULAR and ACR, for training in ultrasound will be in Santa Monica, April the 11th through the 13th. And this is, you'll see it outside, but I'll go back to this. Wolfgang Schmidt from Germany and Maria Antonietta D'Agostino from Paris and Mikkel Ostergaard from the Netherlands will be there. Just to look at this, if you're interested in ultrasound, a great course. I'm going to go back now, and then Alvin and I will discuss this. Thank you, Artie, for that opportunity.
So can I ask the first question to Arn? So, Arnie, if you have a patient like this and you show some very nice erosions, how aggressive would you treat just osteitis? If you just saw osteitis on the MRI but no erosions, is that patient get treated differently?
So that's a perfect time to treat more aggressively. Osteitis, as I mentioned earlier, being the best predictor of future erosions. If you don't see a break in the cortex yet, there's a chance to actually reverse that. There's been a lot of question, a lot of data written about whether or not erosions actually heal. If you consider osteitis as a pre-erosion, but part of an erosion, and you can control that and decrease that, you may actually prevent the subsequent damage and joint space narrowing.
Okay.
All right. Questions or comments for the panelists on the cases or on the imaging in general? Front right, Roy?
So, Oren, I'm going to be nice.
Thanks, Roy.
Why the hell would you need an MRI in that last case? So the reason why I asked the question is you did everything you needed to do, high positive anti-CCP, very active disease, and you're going to treat. Now, if you do the X-ray, and then maybe something on the X-ray, not on the X-ray, you showed a few, how did that change your treatment at all?
Thank you, Roy, for asking that question. I put that second case in, Roy, specifically for you.
Good. So now what's the answer?
The answer is the patient was in a clinical trial, and it was a trial looking at MR changes. Otherwise, I would not have used it in that case. I almost anticipated you being the first one to ask me the question, but the reality is you're absolutely right. I didn't need it. The patient was in high disease activity. We did the usual things. The patient was going to get treated. There was one point there that she was reluctant to go on to further therapy. But even with that, you can be convincing. So the reason for that was this patient was in a clinical trial looking at MR changes early within a 6-month period after biologic therapy.
And then, Alvin, I have a question. Did you want to say something?
I was going to make a comment. So on that patient, I would have done an ultrasound, so I'd have a baseline. So when I'm ready to rev up my therapy or anchor it, notch it down, I would have a kind of a hallmark of where to go. So the ultrasound plays a role in that, and we'll talk about that this afternoon, how we do it for monitoring therapy.
Okay, so that raises another question. So you treated the patient almost appropriately, right? And the patient went into remission, DAS remission. But what was the CDI? Do you remember what the CDI? I know you do it. Was it very, very low? Was it a CDI remission?
I believe it was.
Okay,
I don't remember.
which it could have been.
Yes.
So that would raise the second question. In that situation, would the ultrasound make sense before you began tapering therapy?
Yes, and that's where we began to use it there. The challenging part about the ultrasound, so we know that if somebody has a Doppler signal, then we try to use that to convince the patient, you need to stay on it a little bit longer. We don't want to notch it down. The challenging part is our drugs are so great at dampening the Doppler response. Even NSAIDs, some data came out last year, EULAR said a low dose of prednisone and NSAIDs can blunt the Doppler signal. So when we don't see Doppler, doesn't mean we still don't have active disease. So we go more by the synovial hypertrophy then, and that's why it's good to have a baseline.
So I'll actually be nice, but
Everybody's nice.
no, but I do have a question actually trying to sort through all this. So, and it's for both of you. So in terms of an MRI with an erosion without osteitis, or an ultrasound with erosion without a Doppler signal, how much weight do you place on that in terms of how likely that is to tell you what kind of future progression is in terms of meaningful damage without the activity? I always sort of wonder about that. So, these are very sensitive imaging studies. You're picking up very, small changes, and they may be meaningful, but how do you sort out the ones that are going to be a problem, what's going to be a problem, what's not, without the inflammation? The inflammation makes it obvious.
Right, and that's the biggest challenge, because the question is, are we picking up things that are too sensitive? So with ultrasound, I can definitely comment on there's some joints you don't want to look at, like the first MTP, that you're going to find even somebody like me, got a small bunion, somebody who's running and doing exercise, you're going to see synovitis, you can even see erosions there. So we avoid that, and in the clinical trial, we avoid that. The money image for ultrasound for erosive changes is the radial aspect of the second MCP. If you see an erosion there, even without inflammation, that's pathognomonic for an erosive inflammatory arthritis, and that's what we begin to treat. So that's the joint that we see the most and everything. The trial's been shown that it's the second MCP that we see that. All right?
And similarly with MR, it's a very important question Because as I started to look at this over a decade ago, and even prior to that, others, the question is, how important is it to do this and then to monitor, and do you continue to watch that? So Fiona McQueen published data over a decade ago showing that many of these, actually over half of the erosions that are picked up by this very sensitive technique of MR, don't progress to X-ray erosion. Right. So how important is that?
Right.
So I agree with what Alvin suggested, and it's the joints that are affected, the second and third MCP or wrist, and if there are multiple erosions, not just one erosion, and also the fourth and fifth MTP joints of the feet. So if there's a suggestion that there's one erosion, I'm not going to act on that. Certainly, as you pointed out, if there's osteitis, it's an important time now to act on it, but it's also a predictor. Erosive disease is a predictor of future bad disease and poor outcomes. So one or two erosions, maybe not. Multiple erosions, I'm going to act on that.
The challenging part, and I'll pose this to the audience, is so what do you do now with erosive osteoarthritis? We got these sensitive imaging tools, and now you pick up erosions now, not only in the DIPs, but also in the PIPs. Does that put a patient who's seronegative into a different category? Artie, do you do anything with those patients differently? I know you do ultrasound in your center. Or...
Yeah, well, I think, and that would be the part of the rationale for treating them, as if they were a rheumatoid, and we know that the inflammatory, it's a continuum, and there are some that will respond to our immune modulating therapies, and that I think gives you that much more rationale for being able to do that.
Mm-hmm. To that point, if I could just add to that before we go on, we're doing a study now with MRI looking at erosive osteoarthritis with an IL-1 beta inhibitor. So there's future to that also.
Front right, Glenn?
I want to ask Alvin about the ultrasonography. It is a huge improvement. We have started to look into the joints, and we can do it bedside. Mm-hmm. So it's definitely an improvement. But I was listening to Filippucci from Grass's group, and the improvement in the machines is so good now that you can question that you see too sensitive, and how to distinguish then between normal blood flow and what is due to inflammation. Do you have comments on that?
Yeah, so the biggest thing, remember, and that's where the histology and anatomy goes back. So if you go back and look at the histology of a joint, particularly of an articular joint, the synovium is usually only 1 to 2 cell layers thick. In the setting of an inflammatory arthritis, where you get the synovial hypertrophy, that's where you do begin to see some of these different changes. It is sensitive, so if you're looking at, for example, in the arteries of the hands, you got the palmar arch, you have a superficial and a deep palmar arch. Those can be so sensitive, sometimes you pick up the signal from those arteries, and in some patient I've seen as I review articles that, hey, this is really not coming from the synovium, it's coming from an adjacent artery. So you're looking at those low flow, but this is the user dependent step is looking at the Doppler signal with these very, very sensitive machines.
So, Oren, so in the study that's doing the IL-1 beta, wouldn't an ultrasound be better than an MRI? Forget the fact the MRI is not validated, but...
Well, actually, if it's not validated in osteoarthritis. It is validated in rheumatoid arthritis, as you saw our presentation at ACR a year ago.
Not really, but be that as may. But wouldn't the ultrasound be a better...
So to your point, I think the aspect of looking at synovitis is it's very sensitive to do that, but it cannot penetrate the bone. So if you're looking for osteitis, for a pre-erosive change, the only technique available is MR.
I agree.
But I think that you're looking for inflammation.
Thank you very much. Right. You were being nice. Remember what happened? Don't answer that.
I changed.
All right. Well, I thank our speakers.